so that, a subtle change in an arterial tracing that might indicate something's happening that I might not recognize until, the patient is farther along in a given process. Those are exactly the kinds of algorithms that people are looking at.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
This week on First Case, we speak with Dr. Jesse Ehrenfeld, member of the Board of Trustees at the American Medical Association. Melanie, this is going to be a flash forward kind of to the future, but the future is here now conversation. We're going to be talking about AI, and we're going to get some definitions. We're going to be talking about how the technologies are already being utilized in healthcare, and then really take a look at what it could all mean and how the heck is this regulated?
I think this is such an exciting topic. I know we kind of already touched on it in a couple of episodes of season 2, but to really dive into the regulation side of it and what's the FDA doing or not doing, and how is this affecting our patients, and maybe those questions we should be asking as consumers of augmented intelligence and making sure that we're making safe decisions and good choices. It's just a great conversation, and I'm really excited to talk to him more about it and get his standpoint on everything.
It's funny. We see a lot of people just putting, blind faith into technology these days. Just allow all those permissions on my smartphone app, right? I wonder if that translates to healthcare. We're going to find out. So stay with us. We'll be right back with Dr. Jesse Ehrenfeld, member of the Board of Trustees at the American Medical Association.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Dr. Jesse Ehrenfeld, member of the Board of Trustees at the American Medical Association. And today we are going to be talking about AI and machine learning in the operating room. So I'd love to say that this is a look into the future, but it's here today. Dr. Ehrenfeld, thank you so much for joining us.
Well, thanks for having me. I'm delighted to be chatting with you guys tonight.
I know you had a chance to talk to Melanie before we brought you to the podcast, but I thought maybe you could introduce yourself to the audience and tell us more about your background. Just perusing your LinkedIn profile, you have quite a list of accomplishments.
I stay busy, which is good for my family. No, I've been on the board of the AMA for about 7 years. I'm a practicing physician anesthesiologist. I practice at the Medical College of Wisconsin here in Milwaukee. I've been a clinical informatician for about 15 years, doing a lot of AI development work, clinical decision support, and other technology projects. So it's a space that I'm excited to talk about and is near and dear to my heart.
This is exciting. I like this topic. I've been excited about it since we talked about it last week, actually. But when we talk about AI in the operating room, or we talk about machine learning, there's a lot of different terms and a lot of different words flying around in the air about this topic. So I thought maybe it would be a good idea to break down into some definitions of really what it is we're talking about. I know you've got a bunch of words that people might see when they're reading about this, and it might help to kind of explain what those are a little bit.
Yeah, that's a good place to start. First I'll just say that the AMA uses the term augmented intelligence rather than artificial intelligence, because we really conceptualize the idea idea that AI is assistive in helping us as clinicians enhance our intelligence and capacity rather than replacing it. So when I talk about AI, I'm really talking about from an augmented intelligence standpoint, although a lot of people really continue to use the word artificial. There are three buckets of artificial intelligence, and you'll understand why we like this augmented concept a little bit better. There's artificial narrow intelligence, and that's where you have algorithms that specialize in one area and can solve one problem. Things like Siri, right? It can turn on my lights. There's a specific thing that it's doing. There's artificial general intelligence, which we don't have today. That's a computer that's as smart as a human across the board. And when people in the technology computer world talk about artificial intelligence, that's actually the concept that generally they're speaking about, artificial general intelligence. And then there's that's way out there, which is artificial superintelligence, which is this idea that machines have consciousness. It's a little frightening. Don't have it. It's light years away, but that's the sort of stuff of science fiction as we conceptualize machines that can think on their own, if that makes sense.
Oh, yeah. Definitely. Actually, a side note, I just finished watching through the original Matrix trilogy with my kids, and you get that idea of the super intelligence of machines, and it is quite terrifying. So thinking about it in terms of what we actually are seeing today in the operating room, can you talk a little bit about where we are seeing, maybe not the robots from the Matrix taking over, but what are we seeing in the OR world with augmented intelligence?
Yeah, there's a lot out there. And, when I think about what's happening in sort of my world of anesthesiology, there are people working on, can we use algorithms to do depth of anesthesia monitoring? Can we control our anesthesia delivery systems, the medications being delivered, the ventilators using AI algorithms? There's no shortage of algorithms in the kind of event risk prediction space. So, is this patient likely to have this event? What's the surgical outcome likely to be with this particular set of conditions, or this particular team doing this procedure in this environment? There's a lot of stuff in the logistics space. That's where we're actually seeing implementations happen today. Supply chain management, OR scheduling, some of the stuff around patient follow-up. There are plenty of groups that have actually implemented those technologies today. And then there's sort of image-guided work, AI-enabled ultrasound equipment and technologies. And there's some stuff happening in the pain and device space as well. Those are things that are sort of all out there. Some are actually real, happening today, but it tends to be more on the sort of OR logistics side. And then the things that are kind of in development in the other categories, if that makes sense.
I have a question about what you were just talking about in terms of anesthesia. And I know a lot of the indicators on the patient that are being monitored are now computerized and brought together. Now, is there anything out there yet to help predict if a patient's going to be going into trouble based on all the factors associated with that? Is that sort of what you're talking about is happening or will be happening?
That is an area that people are working on developing right now. So, I was in the operating room this morning. I counted 53 parameters on my physiologic monitors, the anesthesia machines, the things that are there, right? That included 7 continuous waveforms. And of course, I've got lab data, EHR data, reminders popping up, all sorts of things. It's unfathomable to me that a machine couldn't help me consume all that data more effectively, more efficiently, so that, a subtle change in an arterial tracing that might indicate something's happening that I might not recognize until, the patient is farther along in a given process. Those are exactly the kinds of algorithms that people are looking at. So, can we predict when a patient is likely to return to consciousness after general anesthesia, or is likely to, have the hypnotic effect of an induction bolus of propofol actually take over, and then their eyes roll back and they fall asleep, as well as things like, are they going to get hypotensive? Are they going to become septic? All of those kinds of things. So that concept is very much a place that's of active research interest, but you're not seeing today a lot of implementations at scale.
What you're kind of describing is something I remember when I was working in the wellness industry, was this whole predictive modeling, predictive analytics. Is that at the heart of what you're talking about, is like the brains behind this augmented intelligence, the way you just described it?
Yeah, well, that's a great question. And I didn't get into like the subfields of AI, but maybe I'll take a minute to do that now. There are a lot of words that get thrown out: machine learning, neural networks, deep learning, natural language processing, computer vision. All of those words are subfields of AI. And that's where it gets confusing to people, because they'll say, well, geez, there's natural language processing going on that can, scribe for what's happening when someone's doing, something with a patient. Natural language processing is a subfield of AI that allows us to have, a computer that can understand and generate human language, including speech. Machine learning automates analytical model building. And what it does is basically it uses these kinds of methods from neural network development, statistics, to find hidden insights in data without the machine or the algorithm being explicitly programmed on where to look or what to conclude. So at its heart, all of these approaches are trying to use the computer to solve problems in real time, most of the time, in a way that can help us be more effective at what we do in our jobs.
So you made a big distinction early on, too, about shifting the A in AI from artificial to augmented. And I've definitely heard that before. As a matter of fact, our chief medical officer, Dr. Peter Nickel, introduced me to augmented really being the more commonly used term. But the way that I kind of referenced it in my head was artificial is like essentially doing the job for you, and you're relinquishing complete control, almost like the Matrix, the way Melanie just described watching the movies. Whereas augmented, and you're talking about, here are these, notifications that I'm getting and alerts, and maybe it's starting to predict what's going to happen next. Do you think that that's the real key to, I don't want to say it's a switch in nomenclature, but changing it over to augmented? Are we emphasizing that humans still have to be involved with this technology, but at the same time processing data at I would say almost superior or superhuman level?
Well, we don't have in the world today general artificial intelligence where the computer is as smart as the human. Unless I'm missing something, if somebody finds it, let me know. What we do have are these narrow applications of AI algorithms using, machine learning and neural networks and NLP that have great uses across healthcare and can scale capacity, can help us make better decisions in real time. There are anesthesia control delivery systems that have their feedback enabled or closed loop systems that can fully automate delivery of, an anesthetic. The amount of propofol that's being delivered using, blood pressure, heart rate, BIS index, other kinds of measures. Those control systems are real. They're not widely available in the US, but those kinds of algorithms, AI enabled, can in some circumstances more effectively manage mechanical ventilation or automate weaning from a mechanical ventilator than a human can because of the way that these algorithms can work. Now, does the system know which patients to use this in or what clinical context? No, because the scope is pretty narrow of what these control systems are able to do. But there's great promise for what's being brought into the marketplace.
So with the benefits that augmented intelligence and machine learning can provide, like you said, for making better decisions or fully automating anesthesia or these ways that we can implement it into the perioperative world, there have to be challenges associated with it too. Can you talk some about the challenges associated with this technology?
Well, let me start with there's the hype versus the reality, right? So everybody wants it. Everybody expects it. We're in an AI era, right? People, in your experience as a consumer, right? Shopping online, with the recommendations that we get through these sort of very sophisticated algorithms, expect that somebody should be able to help me interpret those 53, data points that are continuous more effectively in the OR. And so everybody wants it. We expect that it's there, but we don't quite have it. And that's a challenge. The AMA does a number of things, including some digital health research where we look at, what are the physicians' motivations as well as requirements for adopting a variety of digital health tools. And we've tracked this year over year. And what's really amazing is that awareness of AI technologies is incredibly high. 78% of, physicians across the country in a representative sample have heard of it. They're aware of it. They have ideas about how it could be used in clinical applications, deliver personalized medicine, how it could help for back-end office operations. Yet adoption is low. It's single digits across the board. And yet in spite of the high awareness, low current adoption, if you ask people, are you going to be using it within 3 years? Everybody says yes. And again, you see incredible high numbers of physicians across specialties, across practices, across geographies, young and old, all saying that they expect these things are going to come into practice within the next 3 years. So I worry about this sort of disconnect between, what's actually here today and available, what you can buy versus the reality. And we'll get there. I know we will, but I think we're also in for a bit of a bumpy ride for a variety of reasons.
Are some of those reasons, or I guess part of me is like technology can only go so fast, right? So some of the applications that we would want to use it for, maybe the processing power isn't quite there enough to take it to the next level, because it's sort of like people think about things and you said, oh yeah, we expect it's going to be there, but they have their own idea of what it's going to look like when it comes. So then when it actually comes, maybe it doesn't quite meet their expectations, or they think to themselves, well, I could do this just as fast, or I don't trust it, or whatever. And there's a human side to that too. So I kind of wonder, do you think it's weighted more towards people's willingness to adopt AI, or more around the technology's ability to quite get it to that final hurdle where it can be easily adopted and people just sort of like, oh, okay, yeah, this works?
Well, there are a couple of things that come up. One is there are 4 questions that the AMA has found in all of our research that physicians want to know before they integrate a technology into clinical practice. And this is across the board for any technology, whether it's AI enabled or not. Number 1, does it work? Is this something that actually helps? Number 2 is, will it be covered and paid for by somebody? So there's the coding coverage sort of equation side of things. Number 3 is, who's accountable, right? So if there's a problem, where's the liability held for the use of a technology? And number 4 is, will it actually work in my practice, with my infrastructure, with my patients? What does the education, training, implementation process look like? So, as we think about technologies, and AI is like any of the others, we've had a bumpy experience. If you just look at the adoption of electronic health records, the number 1 dissatisfier for physicians for years was the EHR. And it's not because, the technology doesn't work. It's because, the usability, the implementation, all of the challenges around the reasons that people just generally don't like the technology. It's not about whether the technology works. It's not whether it can help things. It's about the implementation. And I do worry that the implementation of these tools will run into similar challenges as things come out of the development pipeline if we're not careful.
It seems to me that some of this is age-related. Old people like me have a harder time adapting to this new technology, but as time has progressed, people like me are fading away from healthcare, and the younger folks are stepping in. So they have a much greater ability and knowledge regarding computers in general, as well as all these new technologies. I have a question about the regulatory issues associated with this. How are you going to, I know you said that you wanted to see how it meets expectations. How is it going to be approved within the medical community? Is there going to be some methodology or acceptance that has to be made before it gets implemented into healthcare?
Great question. So right now, we don't have a clear framework for the approval of AI-enabled medical device or software that's acting like a medical device technologies by the FDA. The FDA has been working on this for a long time. They have done a lot of convenings and listening sessions and hearings. They have put out some draft guidance. But right now, we don't have a clear pathway for market approval for a lot of these products. The AMA, I believe strongly that the FDA ought to require clinical validation before products are marketed. That's not a given. The FDA has signaled that they might actually take a different approach where manufacturers, developers, innovators are actually allowed to market products if the entity actually meets certain criteria. So if you think about it, you have a clean lab, a clean facility, a clean bill of health, and you file your taxes, then you can bring a product to market. It's that kind of approach that could be one way that the FDA goes. We don't think it's the right one, but it may be what happens. I think, people are going to want the clinical evidence to support the use of a particular product if we're going to have trust in these products. And trust is a real key issue both for patients and physicians. And I'm happy to talk about that if that's of interest.
Absolutely.
Absolutely.
Yeah. it's kind of scary that they wouldn't want it validated.
Well, I tell you, it's interesting. There's some really good literature. There was a Harvard Business Review article about 3 years ago on this, that about trust in AI in patients and doctors. And the bottom line is that patients are reluctant to use healthcare-enabled AI tools, even when it outperforms human doctors. And you might ask yourself, well, why is that? And it's because patients believe that their medical needs are unique and can't be uniquely addressed by an algorithm. And so in study after study, patients express a strong preference for having a human provider perform the service, even if that means that there's a greater risk of an inaccurate diagnosis or even a surgical complication. And it's not because people believe that the AI provides inferior care. It's because of that issue about the uniqueness of an individual and whether the algorithm can address it or not. So, if we're actually going to get these tools brought into the marketplace, we're going to have to get past this trust hurdle, both on the physician and healthcare provider side, regardless of the FDA framework, as well as on the consumer side. And that is a real concern for me when I think about, how do we get these tools into the marketplace?
When we talked last week before this interview, you actually mentioned questions that consumers should be asking. Can you go into that a little bit further? Maybe the questions consumers should be asking when they're looking at this in terms of their healthcare.
Yeah, absolutely. So, you can go to Google and find an AI-powered dermatology tool that they make. It's available in the EU. It's marked as a Class 1 medical device. It's not available in the US. And you can find it. And basically what it says is that based on photos you take with your phone, their AI-powered dermatology assist tool will offer suggested conditions. Okay, great. So that's out there. How do I know it works? How do I know it works on me if I have darker skin or if I have an underlying condition that maybe makes my skin appear differently, or if I'm older? What happens to my data? Is the vendor going to sell it? Is it going to be traced back to me? How are the privacy issues handled? As these systems evolve, there's this concept of a continuous learning system, which means that as more and more data is accumulated, that the answer might change. So, if I use the tool on Monday and they get more data and the answer changes on Friday, how do I get notified? Does somebody tell me? What if I don't, get that email or it goes to my spam that suddenly, the answer is different? And then what do I do if there's a problem? Do I call 1-800-Google and do I actually get somebody? Those are real issues for consumers. And I, because it's on their website, I can point to this, AI powered dermatology tool because you can find it. This is one of many. There will be thousands of AI powered consumer facing applications that very well may not be FDA regulated that I think consumers are really going to have to figure out how to grapple with. And, as physicians and healthcare providers, we get asked all the time by our patients, about, tools and advice and should I do this or not? I think we're going to struggle to help our patients understand how should they think about these technologies when these come into the marketplace if we don't have the right level of transparency and explainability on the consumer facing side of things.
So what is the involvement of the American Medical Association, and kind of taking a look at this and being ready and making ready for augmented intelligence to really just burst onto the scene, really?
Well, the AMA has taken this on as an important challenge. We've convened really the Federation of Medicine. We've looked at physician perspectives on AI and convened experts to understand, what are the concerns related to how these products are being developed and brought forward. We have, a whole policy compendium. We've written a number of reports about, best practices for adoption, the regulatory framework. We continue to provide our comments to the FDA as they think about, what does AI product labeling look like from an FDA standpoint. We think that there should be required disclosures about, what is the safety and efficacy data for a product. Who's the population that the product was validated in? What are any limitations of the data set? But again, it's not clear that the FDA may require those things for various products to come to market. I do think, if we're going to earn and keep the trust of consumers, whether or not the FDA requires a particular activity to be done, I actually think it's a place where companies will be able to differentiate themselves in the marketplace, which potentially could be helpful. So if there's no requirement for post-market surveillance on a consumer-facing tool that's not FDA regulated, but a company is committed to doing that, then that's a company that I might want to use their product compared to another, for example.
Definitely. All right, I want you to share with everybody listening the story that you told me when we talked last week about the lessons that were learned with augmented intelligence in plane crashes, actually, and how those lessons can be translated into the lessons that we need to learn in healthcare before we really just jump 2 feet in, I guess, to all of the different technologies that we have access to. But would you tell that story?
Yeah, absolutely. Well, the tragic loss of the 2 Boeing 737 MAX airliners gives us really a lesson on how AI systems should and should not be implemented. And the bottom line is that automated systems designed to improve safety can actually create dangers when they malfunction. The 737 MAX crashes appear to both have been caused because an AI safety system malfunctioned. And so I'll get technical here for all the plane buffs that listen. When the 737 MAX redesign was done, the modern high efficiency turbofan engines, they're much larger in diameters than the ones used in the 60s. So if you put them on the original configuration of the plane, you drag it to the ground. So the redesign put the larger engines further forward and higher on the wings so they fit. The problem with that is that it forces the plane's nose to pitch up during some maneuvers. That's dangerous because if you pitch your nose up too high in the plane, you stall and you fall out of the air. So to mitigate this problem, this AI-enabled design safety system was put on the plane. And what happens is when this AI system detects that the nose is too high, it literally forces the nose of the plane down. The problem is that if you have a sensor malfunction, the plane's cruising along normally, and suddenly the sensor tells this AI system that the nose is high, then it forces the nose into the ground. And that appears to be what happened with those crashes. So what does this have to do with medical workflows? Well, the people in the workflow have to know that the AI is there. We have to receive training on how it's expected to work and not work. We can only supervise and correct AI if we know about it. And I'll tell you, the flight crew of those 2 planes that crashed were not aware of the existence of this new AI system. It was absent from the operations manual. There was no specific training required. We simply cannot repeat that same mistake in healthcare.
Well, so as we kind of paint a picture for the future, I know maybe you're going to tell Melanie it is the Matrix, but what lies ahead, and maybe paint a very distant future kind of look for what this is going to be in healthcare, and maybe some key steps along the way. Like this will be a big advancement coming up when we know we're going to hit this target at some point. This would be a big advancement, and then a few stages if you kind of have that far out in mind.
Yeah, so we have tremendous healthcare challenges today, and you think about all of the incredible pressure that COVID and the pandemic have placed on all of our healthcare systems. We don't have enough people and capacity to deliver the services that we need to. AI should be able to help us with that. AI should be able to allow us to scale the delivery of healthcare in all sorts of settings across the world, because we do have a global healthcare challenge where we just don't have enough people to deliver the care that's necessary. Today, we see, AI systems doing schedule optimization, AI systems doing, personnel utilization work. Those are helpful. They're back-end. They're useful. There is tremendous opportunity in the control system, event prediction space that I think is really, really exciting and is likely to come see us in the future. I get asked, is AI going to replace, you as an anesthesiologist? And I think the answer is no. But I'll tell you, I do think that anesthesiologists who use AI will replace those who don't. And I think that's likely to happen across all of healthcare.
That's great. Well, I got to tell you, Dr. Ehrenfeld, this was a great interview. We've had some parallel conversations, but not so much in the care delivery part of this conversation, and really how it all comes together from really an infrastructure, as you mentioned, with the trust and how is it going to be regulated. I think those are all really important questions that need to be asked and addressed. And it sounds like the work that you're doing at the American Medical Association is really leading the charge. So I just want to thank you for coming on the show and ask if there's anything you'd like to add before we wrap up.
Well, I'll just close by saying that, AI is best optimized when it's designed to leverage human intelligence once deployed. Dr. Abraham Verghese out at Stanford wrote something that I really like, which is the way is not to think technology versus human, but to ask how they come together, where the sum can be greater than the parts for an equitable, inclusive, human and humane care and practice of medicine. And I really firmly believe that, and I'm excited to be a part of hoping to see this future unfold.
All right, great job. Thanks for coming on. That was Dr. Jesse Ehrenfeld, member of the Board of Trustees at the American Medical Association. We're talking about augmented intelligence in the OR, and I love how he broke down sort of all the different types of categories of AI, because I've heard a lot of those words before. Many people out there are familiar with augmented reality or virtual reality. That's like one component of it. But I think it's really the predictive analytics, the modeling, the processing and insights that's coming from data that really is just not within our grasp as humans that has the biggest potential to be impacting and directing care, as we talked about on this episode today, Paul.
Yeah, the thing that I really liked about this was it really helped me to visualize how augmented reality can help the physician. It's enhancing their ability to diagnose and treat versus replacing their ability to diagnose and treat. And to me, that is, a very big distinction and makes so much more sense. Yeah, I learned a lot in this episode because I'm an old guy and I don't know all this fancy stuff. I really appreciate it.
Well, while we're throwing around all kinds of acronyms, how about ROI, or return on your investment? If you can make the procedure go faster and deliver higher quality care, that is absolutely going to save you on the cost of each OR minute and the cost of hospital readmission. So if we can do a better job and we can do it more quickly, there's definitely an ROI and business implications to not just having the fancy technology in the room to help us out as well. So that's going to do it for this week's show. But as a reminder, you can help support First Case by subscribing on Apple, Amazon, or Google Podcasts. We're also available on Stitcher, iHeartRadio, Spotify, or simply search for First Case on your favorite podcast application. For some of these episodes, we've got bonus content, but you've got to download our smartphone app for iPhone or Android and just click on the gift box within each episode. While you're there downloading the app, we'd appreciate a rating and a review because your feedback is important to the show. And on behalf of Paul, Melanie, and myself, thank you for listening to this week's episode of First Case.